Welcome students to our new YouTube channel Pharma X Tech, the division of excellence. So in the last video lecture we will see the antihypertensive drugs. In that we see the direct vasodilators, then next we see the calcium channel blockers, then next in this video we will see the diuretics is used in the antihypertensive drugs. So let's start to the diuretics. The diuretics decreases the blood volume, thus decreasing the total peripheral resistance. And the example of diuretic is hydrochlorothiazide. The hydrochlorothiazide is a representative thiazide diuretic, and various drugs can serve as alternatives. This hydrochlorothiazide is available in tablets form. The hydrochlorothiazide 25 mg tablet. Next we see the uses of hydrochlorothiazide. The uses of hydrochlorothiazide is used alone in mild hypertension and in combination with other drugs in moderate to severe hypertension, heart failure and edema. Then next we see the contraindications of hydrochlorothiazide. Contraindications include in severe renal or severe hepatic impairment, hyponatremia, hypercalcemia, refractory hypokalemia, symptomatic hyperuricemia and Addison's disease. In these cases, the hydrochlorothiazide is not used. Then next we see the precautions of this hydrochlorothiazide. The precautions include in renal and hepatic impairment, pregnancy and breastfeeding, elderly the reduced dose, and it may cause the hypokalemia, and also it may aggregate diabetes mellitus and gout, and may exacerbate the systemic lupus erythematous and porphyria. So next we see the dosage of hydrochlorothiazide. Hydrochlorothiazide is used in hypertension and dosage is by mouth, that means by oral route, and in adult the dose by oral route of administration is 12.5 to 25 mg daily, and in elderly patients initially 12.5 mg daily dose is given. So next we see the most important adverse effects of this hydrochlorothiazide, and adverse effects include fluid and electrolyte imbalance, hypotension including postural hypotension and oliguria, arrhythmias, hypokalemia, hypomagnesemia and hyponatremia. These are the adverse effects of hydrochlorothiazide. So next we see the antihypertensive drugs for the treatment of hypertensive in emergency or in urgency. So the first drug is used in emergency is sodium nitroprusside. The sodium nitroprusside is an extremely potent vasodilator. We see in the direct vasodilator, and with a rapid onset and a short duration of action is T half is equal to 1 to 2 minutes. So the action of sodium nitroprusside is short duration and this action is very fast, that means rapid, and the short duration is 1 to 2 minutes. So the sodium nitroprusside decreases the preload venodilation and afterload arteriolar dilation to a similar degree. In hypertensive patients, reduces the cardiac output and increases the heart rate. However, in patients with heart failure, the sodium nitroprusside increases the cardiac index and cardiac output and stroke volume and reduces the heart rate. And also the peripheral vasodilator effects of sodium nitroprusside are due to a direct action on arterial and venous smooth muscle cells. Other smooth muscles tissue and myocardial contractility are not affected. The sodium nitroprusside is rapidly metabolized into cyanide radicals, which are in the liver converted to a thiocyanate, a metabolite excreted almost entirely in the urine. Therefore, the sodium nitroprusside is relatively contraindicated in the patients with severe liver or renal diseases. And the cyanide toxicity is rare unless large doses of this sodium nitroprusside are administered to patients with renal insufficiency. The thiocyanate toxicity can also occur in patients with renal insufficiency who receives sodium nitroprusside, but the onset is slower than the cyanide toxicity. And the adverse effects usually related to the abrupt reduction in the blood pressure include the nausea, vomiting, tachycardia, hypoxemia and corneal steal phenomenon. The corneal steal phenomenon is the major adverse effect of this sodium nitroprusside, and these all common side effects like nausea, vomiting, tachycardia and hypoxemia are the common side effects of these antihypertensive agents. And also the sodium nitroprusside may not be a drug of choice for the treatment of hypertension in emergency in patients with acute coronary insufficiency, aortic dissection, severe preeclampsia and eclampsia, and increase the intracranial pressure. So next drug is nitroglycerine. So this nitroglycerine is an organic nitrate available in various dosage forms. It is converted in the vascular smooth muscle cells to nitric oxide, a free radical which activates a guanylate cyclase, that means guanyl cyclase, and the subsequent increases the CGMP leads to relaxation of vascular smooth muscles, and with the exception of greater effects on venous pooling and beneficial redistribution of coronary blood flow, the nitroglycerine shares the pharmacological profile of sodium nitroprusside. The nitroglycerine may be considered the drug of choice in hypertensive patients with post-coronary bypass hypertension and acute coronary insufficiency or acute chronic heart failure when blood pressure is only slightly increased. And this nitroglycerine it should not be used in patients with increased intracranial pressure, glaucoma, severe anemia and constrictive pericarditis, and it should be used with the caution in elderly patients and volume depleted patients and patients with hepatic diseases. In patients with hepatic diseases, there is increased risk of methemoglobinemia. So next drug is Nicardipine. So this Nicardipine is a dihydropyridine calcium channel blockers used intravenously for the treatment of post-operative hypertension or hypotension with increased the intracranial pressure. And this Nicardipine has similar pharmacological profile with other calcium channel blockers and is presumably more selective for cerebral and coronary blood vessels. So the next emergency drugs is Ismolol. This Ismolol is a beta-1 selective beta blocker administered via the continuous IV infusion, that means intravenous infusion, because of the extremely short duration of action of this Ismolol, and thereby it is useful for acute control of hypertension or certain supraventricular arrhythmias, except for short half-life and duration of action. Ismolol has similar pharmacological profile to the beta blockers 5. Then the next drug is Fenoldopam. So this Fenoldopam is a selective agonist at dopamine A1 receptors used intravenously for acute treatment of severe hypertension, and this Fenoldopam dilates the renal and mesenteric vascular beds via stimulation of postsynaptic dopamine A1 receptors, and the blood pressure and total peripheral resistance are lowered while the renal plasma flow is enhanced, and the onset of action is greater than 5 minutes and the duration is about 30 minutes, and the adverse effects appeared to be dose related and including flushing, headache, nausea, vomiting, tachycardia and hypotension. So these are the adverse effects of Fenoldopam. So next we see the drugs given by intermittent intravenous infusion, and the drugs given by intermittent intravenous infusion is, first one is labetalol. This labetalol is a combined alpha plus beta adrenergic receptor blocker. So next is enalaprilat. So this enalaprilat is a ACE inhibitor, and this enalaprilat is the active metabolite of prodrug enalapril. So in the GPAT there is a question, which is active metabolite of prodrug of enalapril, and the right answer is enalaprilat. So next is Diaz Oxide. The Diaz Oxide prevents the vascular smooth muscles contraction by opening the potassium channels, that means Kepler channels, and stabilizing the membrane potential at the resting level, and Diaz Oxide induces the rapid fall in systemic vascular resistance and blood pressure. This blood pressure associated with substantial, substantial tachycardia and an increase in cardiac output. This Diaz Oxide causes the renal salt and water retention, which can be avoided if the drug is used for short periods only, and it inhibits the insulin secretion and induces the hyperglycemia, and it is used for the treatment of hyperinsulinon related hypoglycemia. So next we see the antihypertensive drugs for special populations, and in that first one is hypertension in elderly peoples. So in elderly peoples, the hypertension is aging was associated with an increasing the frequency of hypertension as well as an increasing the severity, while men between the ages of 20 to 59 years have a higher incidence of hypertension than their female counterparts. The reverse is true in the older population. The hypertension is more common among women aged 60 years and or older than among men in the same age group of 80 years, and 75% in women and 60% in men. Hypertension symptoms are shown. So next we see the benefits of antihypertensive therapy in the elderly greater than 60 to 65 years are 2 to 4 times greater than in younger population, and the blood pressure should be measured in both sitting and standing position. The standing blood pressure should be used as the guide to therapy, and the presence of pseudohypertension due to the increased vascular stiffness, white coat hypertension especially in older women, and abscess and end organ damage may suggest the presence of these factors. And also the non-pharmacological treatments, as per Tone study in 1988, the likelihood of remaining free of drugs treatment after 30 months increased by the 60% with salt restriction and 50% with weight reduction, and by 15% with both salt restriction and weight reduction. And the pharmacological treatments includes the lower initial dosage, that means half dose than in younger patients, and the reduction in BP should be gradual, greater caution in patients with coexisting diseases or orthostatic hypotension. And recommended therapeutic goals is 85 to 90 mmHg in patients with diastolic hypertension, and the systolic blood pressure below the 160 mmHg, and if initial systolic blood pressure is greater than 180 mmHg, the systolic blood pressure reduction of minus 20 mmHg, and if initially is 160 to 180 mmHg. So the thiazide diuretics, AC inhibitors, and long-acting calcium antagonists and beta blockers may all lower the blood pressure and stop hypertension trials. The diuretics and beta blockers reduce the mortality rate. So in hypertension in elderly patients, these drugs that lowers the blood pressures are thiazide diuretics, AC inhibitors, long-acting calcium antagonists, and beta blockers. So these are all drugs, or these subclass types are may lower the blood pressure and stop hypertension trials. They are diuretics and beta blockers, reduces the mortality rate also. So next we see the hypertension in diabetic patients. So hypertension is common problem in diabetic patients. In IDDM, the incidence of HTN is 5% at 10 years, and 30% at 20 years, and 70% at 40 years. Close relationship exists between HTN and renal disorders. The blood pressure rises the 3 years after microalbuminuria, and the HTN in 15 to 25% of microalbuminuria uric patients. The HTN in 75 to 85% of patients with over nephropathy. In NIDDM type 2 diabetes, the 40% hypertension before microalbuminuria patients occurs. And remember that the kidneys in diabetic patients are more sensitive to an increase in blood pressure, and proteinuria is not only the marker of renal damage but also a risk factor of progression of renal and cardiovascular diseases is proteinuria. So next we see the treatments of these hypertension in diabetic patients. So in early treatment to prevent the cardiovascular diseases and minimize the progression of renal and retinal diseases, and also the benefits of tight blood pressure control in diabetes may be as great or greater than benefits of strict glycemic control, and initial therapy should include the non-pharmacological methods like weight reduction, exercise, sodium restriction, avoidance of smoking and excessive alcohol ingestions. And the normal blood pressure is to prevent the cardiovascular diseases in diabetic patients is 130 by 85 mmHg. And ACE inhibitors is a drug of choice for diabetic hypertensive patients. So in the GPAT there is a question, which is the drug of choice for diabetic hypertensive patients, and the right answer is ACE inhibitors. And when these ACE inhibitors does not produce the desired level of blood pressure control, the low dose of long-acting, that means thiazide or thiazide-like diuretics, is an appropriate second agent. The ACE inhibitors plus diuretics normalize the blood pressure in over 80% of patients with diabetes and hypertension. Combination of ACE inhibitors and angiotensin receptor blockers or ACE inhibitors plus calcium channel blockers may be considered in diabetic patient with resistant hypertension and or over the proteinuria. So next, the major we see the hypertension in patients with ischemic heart disease. The ischemic heart disease is the most common form of target organ damage associated with the hypertension. And the beta blockers and long-acting calcium channel blockers are the first choice in hypertensive patients with stable angina pectoris. And in hypertensive patients with unstable angina or myocardial infarction and also the elevated blood pressure should be treated with beta blockers or ACE inhibitors. And also in the patients with post myocardial infarction and ACE inhibitors, beta blockers and aldosterone antagonist reduces the progression of the left ventricular dysfunction and mortality. So next we see the hypertension in patients with the heart failure. So in the patients with heart failure, the ACE inhibitors and beta blockers are recommended for the treatment of hypertensive patients with the asymptomatic ventricular dysfunction. And in hypertensive patients with symptomatic ventricular dysfunction, NYHA 3 and 4, in addition to ACE inhibitors and beta blockers, the treatment of diuretics, angiotensin 2 receptors and antagonists and aldosterone antagonists is recommended. And in hypertensive in heart failure patients, if volume depleted, the ACE inhibitors may induce the hypotension and acute renal failure, and the beta blockers may induce the initial or transient worsening of chronic heart failure. So at last we see the most important, that in hypertension in diabetic patients, the ACE inhibitors is the drug of choice for diabetes in hypertensive patients. And in hypertension patients with ischemic heart disease, the beta blockers and the long-acting calcium channel blockers are the first choice in hypertensive patients with stable angina pectoris. And at last, the hypertension in patients with congestive heart failure, the ACE inhibitors and beta blockers are recommended for treatment of hypertensive patients with asymptomatic ventricular dysfunction. And in hypertensive chronic heart failure, if volume depleted, the ACE inhibitors is the right choice for this. The ACE inhibitors may induce the hypotension and acute renal failure, and the beta blockers may be induce the initial or transient worsening of chronic heart failure. We will see the whole classification of antihypertensive drugs. These drugs are used in the cases of hypertension. So in these antihypertensive drugs, the first class is diuretics, and the loop diuretics and thiazide diuretics and potassium sparing diuretics are used in hypertensive drugs. So the loop diuretics like bumetanide, ethacrenic acid, furosemide and torsemides are used. And the thiazide diuretics like eptizide, hydrochlorothiazide and chlorothiazide, bendroflumethiazides are used. And thiazide like diuretics are indapamide, chlorthalidone and metolazone are used. And the potassium sparing diuretics like amiloride, trimethoprim and spironolactones are these potassium sparing diuretics in antihypertensive drugs. So next we see the adrenergic receptor antagonist, and the adrenergic receptor antagonist is first one is beta blockers, and examples like atenolol, metoprolol, nodolol, propanol, pindolol, propranolol and timodolol and nodololoxoprenolol. So these are the beta blockers. So or the lol are used in hypertensive drugs. These are atenolol, metoprolol, naldoxoprenolol, pindolol, propranolol and timolol. So these are selected beta blockers used in hypertensive drugs. So next is alpha blockers like doxazosin, phentolamine, phenoxybenzamine, prazosin in fainting and postural hypotension. And side effects always taken these prazosin is always taken at bedtime, and also terazosin, tolazolin and mix alpha plus beta blockers and bucindolol, carvedilol and labetalol are used in adrenergic receptor antagonist. So next we see the AC inhibitors. The AC inhibitors like captopril, enalapril, fosinopril, lisinopril, quinapril, ramipril and benzapril. So all these pril, the drugs ending with pril are the AC inhibitors, and these drugs persistent cough is common side effect of these AC inhibitors. So the next one is angiotensin 2 receptor antagonists, and they are losartan, candesartan, irbesartan and olmesartan, valsartan and telmisartan. The words that ends with sartan, these are angiotensin 2 receptor antagonists, and the words ends with pril, they are ACE inhibitors. So these are for the tricks for understanding the drugs. So the next one is, and also for remembering the drug names and their classes. So next we see the calcium channel blockers, in that dihydropyridines is the prototype agents in this group is nifedipine is a first generation dihydropyridine, and second generation agents include isradipine, nicardipine and felodipine. These are the second generation calcium channel blockers, and amlodipine is considered a third generation dihydropyridine. Next is non-dihydropyridines, and non-dihydropyridines like dilitazem. Also this is benzothiazepine derivatives, and verapamil is phenylalkylamine derivatives. So next we see the centrally acting adrenergic drugs. Alpha 2 agonists are clonidine. This clonidine is marked rise in blood pressure. This rise in blood pressure is a side effect of clonidine. And also the alpha methyl dopa, in that positive Coombs test as hypersensitivity reaction, and guanafacine are the centrally acting adrenergic drugs, alpha 2 agonists. So next we see the vasodilators like Diaz Oxide. This is potassium channel opener, and hydralazine through no generation, paranesthesias, lupus erythematosus are the side effects of hydralazine, and the sodium nitroprusside through no generation, and the minoxidil. In minoxidil, this is potassium channel opener in male BNS, or in alopecia mainly this minoxidil is used. So next we see the aldosterone receptor antagonists. The aldosterone receptor antagonists are spironolactone and epinephrine. So these spironolactone and epinephrine are the aldosterone receptor antagonists. So next we see the adrenergic neuron blockers, and the adrenergic neuron blockers are gonethidine. These gonethidine displaces the Na not applicable. These displaces not applicable for the storage granules, and release not applicable is degraded by MAO inhibitors, and weakness is a side effects of the gonethidine. And also the reserpine. This reserpine inhibits the granular uptake of noradrenaline, so not applicable, or sodium is progressively degraded by monoamino oxidase enzyme. Suicidal tendency is the side effects of this reserpine. So at last we see the drugs used in hypertension classification in short. So we see that the diuretics, in that thiazides like hydrochlorothiazide, chlorthalidone, and loop diuretics like furosemide and bumetanide, and potassium sparing diuretics like triamterene and amiloride, and sympatholegics are carotid sinus sensitizers, veratrum alkaloids, and also the centrally acting agents like clonidine, methyldopa, and guanabanes and guanafacine are the centrally acting agents, and also the ganglionic blockers like trimethophan and hexamethonium are the ganglionic blockers, and ganglionic neuron blockers are reserpine and guanethidine, and the alpha adrenoreceptor blockers are prazosin and phenoxybenzamine and phentolamine. So these prazosin, phenoxybenzamine and phentolamine are the alpha adrenoreceptor blockers, and the beta adrenoreceptor blockers like propranolol, metoprolol, and vasodilators in arterial hydrolyzing minoxidil Diaz Oxide, and arterial and venous the sodium nitroprusside, and the calcium channel blockers like nifedipine, verapamil, dilitazem, nicardipine, and nimodipine, and nitridipine and amlodipine, and also the angiotensin converting enzymes, that means AC inhibitors like captopril, enalapril, lisinopril, quinapril, and all the prils, and these all the prils are used in hypertension. And at last the angiotensin receptor 81 angiotensin 1 antagonist is losartan, and all the sartans are used in hypertension. So in this way we completed the topic antihypertensive drugs, in that we see the direct vasodilators, calcium channel blockers, and diuretics, and drugs used in emergency and in special populations. So and also we see whole the classification. So in this way there is the end of this chapter. Hope you like this chapter, anti-hypertensive drugs. If you don't, welcome students.